Hi everyone, my name is Annalise Rahman-Filipiak. I am a neuropsychologist and assistant professor at the University of Michigan, where I have the honor of being the co-lead of our outreach, recruitment, and engagement core of the Michigan Alzheimer's Disease Research Center. Very happy to provide this Dementia for Scientists curriculum offering, focused on Alzheimer's disease biomarker testing and disclosure, the ethical, practical, and cultural considerations. I have no conflicts of interest to report. We have several objectives to cover today. Following viewing of this material, you should be able to describe current approaches to feedback and biomarker disclosure, including evaluating fitness and decisional capacity for biomarker testing, pre-test educational strategies, feedback practices, and strategies for risk evaluation and management following disclosure. You should also be aware of the cultural considerations for disclosure. And finally, you should be able to discuss the major ethical and practical considerations associated with both biomarker testing and disclosure, as well as some potential solutions. There are several topics that I will be covering during this recording, and some that I won't. I'll start by reviewing an overview of Alzheimer's disease, as well as Alzheimer's disease biomarkers. I will also discuss those practical considerations for biomarker disclosure, as well as the ethical and cultural considerations. I should note that I won't be covering several topics. First, it would be impossible in just one recording to provide a comprehensive list of all AD biomarkers and genetic factors. Biomarkers are certainly a moving target, and so it would be very challenging to even provide a fairly comprehensive list. And the information I'll be providing today is somewhat agnostic to the type of biomarker discussed. I also won't be addressing any critiques of the ATN or ATNV model. Similarly, I won't be discussing critiques of the amyloid hypothesis. And finally, while a relevant context for the information we'll be talking about today, I won't be discussing the strengths and pitfalls of anti-amyloid and other disease-modifying therapies. Let's start by talking about why biomarkers matter. As many of you viewing this likely know already, Alzheimer's disease rates are on the rise. In the most recent iteration of the Alzheimer's Association Facts and Figures document published in 2023, there was an estimated 6.7 million Americans living with dementia Alzheimer's type. Please note that throughout the rest of this discussion, I will be using this term, dementia Alzheimer's type, or DAT, to describe individuals who are diagnosed with dementia that is presumed to be due to Alzheimer's. Note that that is different than Alzheimer's disease, which is the underlying etiology potentially driving cognitive difficulties. In addition to these known increases generally, we see that women are at approximately twice the risk of developing dementia Alzheimer's disease as compared to men. Rates of Alzheimer's disease are increasing for all older adults, likely because of an aging population, but additionally because we're getting better at detecting it, and also we're experiencing a greater burden of chronic medical comorbidities, environmental toxins, etc. However, the increase in rates is also happening disproportionately, affecting more individuals coming from communities of color. Now, this is a study by Maeda and colleagues from several years ago that followed Medicare beneficiaries over 14 years. And in this study, they found that Black and African American older adults, as well as Native American and Alaskan Native older adults, had greater rates of dementia incidence over time. This was even true after controlling for the known factors that tend to drive health disparities, including things like cardiovascular risk factors and healthcare utilization. So even after controlling for those known disparities, they saw that Black and African American older adults were at a 40% increased risk compared to non-Hispanic whites. This is actually a relative underestimate, with other studies finding that Black and African American older adults may have a twofold risk for developing dementia. Of note in this study, there was no difference found between non-Hispanic whites and Hispanic or Latino populations, but this is likely because the majority of Hispanic participants in this study were Mexican American, who tend to have very similar rates of dementia compared to non-Hispanic whites. But we know that Hispanic and Latino ethnicity is not a monolith, it's an incredibly heterogeneous group of individuals, and other studies that have focused on Hispanic and Latino incidence rates have found that they are indeed at greater risk for developing dementia as well. We also know that a diagnosis of dementia Alzheimer's type comes with significant, tremendous costs. Again, the most recent estimates from the Alzheimer's Association Facts and Figures document suggested that $345 billion were paid towards dementia-related conditions in 2023, 87 billion of which, so over a quarter of which, were out-of-pocket costs. When we look at why this is occurring, this is because when we compare individuals who have dementia versus individuals who have similar comorbidities but no dementia, those with dementia tend to incur more inpatient hospitalizations, require greater specialty care services and home health services, more medications. They also have more falls and other kinds of emergencies. One of the things that we don't talk about a lot is the caregiving cost of dementia Alzheimer's type. So in addition to that $345 billion that we just discussed, there are significant costs associated with being a caregiver. For instance, we know that currently 11.5 million Americans are currently serving as unpaid caregivers, which results in about $340 billion in lost wages. And again, we see that this loss of income and the associated financial effects are disproportionately affecting communities of color. For instance, Black care partners are more likely to provide full-time care. What this means is that they're providing care at 40 hours a week or more. You can imagine the downstream effects that that might have on ability to work, maintain social relationships, and engage in self-care behaviors. Additionally, we see that Black care partners are unlikely or less likely to use respite care services. However, it's not just Black care partners. We see that Black, Hispanic, and Asian American care partners have greater care demands, less formal assistance, and greater reports of depression. So why do these differences exist? We know that race is a social construct, and it's much more important to consider the many different structural and systemic factors that are likely driving differences in dementia diagnosis, treatment, caregiving, etc. This is a really nice figure from Miranda and colleagues that talks about some of the potential structural and systemic barriers or drivers of disparities in Alzheimer's disease and associated dementia. Now we're going to be talking a bit more about this figure later on in this discussion. Now let's shift gears a bit and talk specifically about Alzheimer's disease biomarkers. Many of you will be familiar with these curves. These are the ATNV curves, or ATN curves that were originally proposed by Cliff Jack and colleagues in 2018. And the goal of developing this biological definition of Alzheimer's disease was specifically for research purposes, to be able to harmonize the way in which we define and measure Alzheimer's disease neuropathology and characterize participants based on that. I want to map onto this some of the clinical features of Alzheimer's disease as well. So generally, to walk through these curves a little bit, we see that Alzheimer's disease is characterized by A, amyloid, T, tau, and N, neurodegeneration. It is presumed that amyloid builds up earliest in this disease continuum, eventually triggers some kind of buildup of tau. Those two collectively contribute to neurodegeneration within the brain and associated cognitive impairment. An individual who's characterized as normal would have no or low Alzheimer's disease biomarkers and would not have any symptoms. Someone in the preclinical stage of Alzheimer's disease would have evidence of elevated amyloid or tau, or neurodegeneration. However, they do not have symptoms. The prodromal stage of Alzheimer's disease, also known as mild cognitive impairment due to AD, would be the case when someone has evidence of amyloid and tau and possibly neurodegeneration, as well as mild symptoms. However, these symptoms would be relatively mild and circumscribed, and therefore not contributing to functional dependence. And finally, when an individual qualifies for a diagnosis of dementia, they have all of those things in addition to significant symptoms that are making it challenging to live independently and take care of those daily tasks by themselves. While it's not the goal of this talk to cover comprehensively all of the AD biomarkers, it is important to go into a bit more detail about some of the most common players. The first is beta amyloid, or A-beta. A-beta is a toxic and aggregation-prone polypeptide that is formed through the cleaving of the amyloid precursor protein. We don't totally understand why this happens, likely genetic processes as well as other processes that contribute to the unusual biosynthesis, accumulation, and clearance, and eventually leads to the buildup extracellularly of these amyloid plaques. These plaques can contribute to oxidative stress and eventually to cell death. There are many different isoforms of A beta that may contribute different roles in this AD pathological cascade. A beta 42 is most commonly found in those amyloid plaques. That is the most toxic isoform. A beta 40, in contrast, is more commonly found in cerebral amyloid angiopathy, another clinical feature or imaging feature of Alzheimer's disease. Some people also use the A beta 40 to 42 ratio, as this may be a more sensitive and specific indicator of Alzheimer's disease. One reason why we think it might be a better indicator is in part because it normalizes for the overall amount of amyloid produced. In addition to amyloid, we also look at tau, the T in the ATN model. Tau is a microtubule-associated protein found primarily in neuronal axons. In the case of Alzheimer's disease, tau is found in this abnormally hyperphosphorylated form, so it has about 3 times as many phosphorylation sites as in normal tau. When this hyperphosphorylated tau accumulates in neurofibrillary tangles within the axons, it tends to destabilize the overall microtubule structure, interfere with neuronal connectivity, etc. And eventually, of course, also leads to cell death. There are 2 commonly found sort of biomarkers of tau, total tau, which is a metric of overall amount of tau. This is seen as a state marker. It tells us a little bit about the overall severity of brain injury or level of neuronal degradation. In contrast, phosphorylated tau is very specific to Alzheimer's disease. So where t-tau can be elevated in other kinds of injuries or disorders, things like head injury or stroke, p-tau is pretty specifically found in Alzheimer's disease. A last marker that we sometimes look at is neurofilament light, or NFL. This is another marker of neurodegeneration and potentially of disease progression. It might be elevated slightly later in the disease process. And just like tau, it is more of a state marker and not necessarily specific to Alzheimer's disease. So as I mentioned, these are the main players that we might be talking about, but there are many, many more AD biomarkers and more being discovered and developed every day. As with the following slide about AD biomarkers, it would be challenging for me to discuss all of the many advancements in AD biomarker development and validation that have occurred over the course of the past decade or so. But I do want to point out several of the different advancements that have really made biomarker testing and biomarker disclosure so important right now. At this stage, we have several FDA-approved tracers for PET scans to measure amyloid and tau. Those include AMVID and TauVid. Additionally, CMS has recently removed the conditional approval of amyloid PET, and instead, in October of 2023, have indicated that amyloid PET scans are appropriate for clinical use, including serial scans, which is really relevant when we talk about disease-modifying therapies and monitoring over time. With that said, it is important to note that CMS approval and allowing Medicare coverage for amyloid scans does not necessarily mean that everyone will have access to those. The Medicare approval is still kind of a regional level decision, and there will still be participants and patients who don't have access to PET at all. Another major advancement that has accelerated progress in the AD biomarker space is the advent and approval of the disease-modifying therapies. Things like aducanumab, lecanemab, and now donanemab have really received a lot of attention and are a step forward in AD treatments. All of them require evidence of amyloid positivity on biomarker testing, which means that we have to develop methods to be able to measure reliably and also disclose this information in a way that's useful for patients and allows them to take part in not only the studies but the treatments. Finally, there has been massive progress in the blood and plasma-based biomarker space. Just a couple of years ago, there was the development of an AD blood test that was commercially available and remains commercially available by by prescription. It is important to note that there is currently no FDA-approved blood test, in part because these blood tests are falling under a category of FDA regulatory oversight that doesn't require the same level of scrutiny. One thing that is coming down the pipeline is a direct-to-consumer test. In fact, just last year, there was one direct-to-consumer blood test that was on the market and commercially available. It has since been pulled, but it is important to note that soon there is likely to be a test that is similar to the ApoE test that can be conducted through 23andMe and Ancestry.com. So there's a world in which these biomarker tests, if in a blood test format, could be translated not only to specialty care, but primary care and directly out to our patients and community members. While the goal of this talk is not to go through in detail the risks, benefits, or relative strengths and weaknesses of different biomarker modalities, it is important to note that we have several at our disposal. So previously, the only way to really confirm an etiology was postmortem examination of the brain. While that still remains a gold standard to identify the multiple likely comorbid etiologies that are driving a person's cognitive difficulties, it's not particularly helpful to clinical patients at the time that they're still living and looking for treatment. There's CSF or lumbar puncture. Benefits include it being highly accurate, highly reliable, relatively low cost. You can get a range of different markers from one sample. However, it does tend to be invasive and painful as it requires a spinal tap or a lumbar puncture. And there's a lot of mystery and intimidation around that kind of method, which means that it's not something that's highly accessible or seen as very comfortable by broad populations. Additionally, like many other biomarkers, there's no agreed upon analytic method or cutoff. More recently, there's been a lot of focus on PET scanning. Just like CSF, there's high accuracy. In addition to providing information on the overall amount of a certain biomarker present, a PET scan can also tell us a little bit more about the distribution, so where that biomarker, where that abnormal protein is located throughout the brain. Additionally, PET scans tend to be non-invasive. There are multiple FDA-approved tracers. However, there are significant disadvantages, the first being cost and access. Not everyone has a PET scanner lying around. Similarly, for patients, PET scanners are normally present in larger hospital systems, academic medical centers. So folks who are living in rural areas or lower access areas may not have that kind of technology access. Additionally, there is radiation exposure, though it is fairly minimal. It ideally also involves an MRI scan, which can be used again to help quantify exactly where these abnormal proteins might be located, but that requires another scan, more money, more time, more access. Just like lumbar puncture, there are no truly agreed upon analytic methods or cutoffs, and there are few tracers for pathologies other than amyloid and tau. In the case where we know that most cases of dementia are driven by multiple etiologies, this is a real shortcoming. As I mentioned, most recently there have been significant developments in blood and plasma-based biomarkers. The evidence is still accumulating. It's highly accessible and non-invasive and relatively cheap compared to the other methods that we've discussed. This could really mean an opportunity for a broad clinical translation, not only to specialty care clinics, but also to primary care and well beyond. However, a major challenge is that, at least at this time, as we'll talk about later, the growing evidence tends to be in samples who are mostly white, mostly high educated, mostly healthy in terms of other medical comorbidities, and individuals from underrepresented groups are not represented in these samples. So we're still trying to determine whether the cutoffs developed in these primarily non-Hispanic white populations work in other groups. There is a regular agreement with PET scans, so not always perfect agreement with PET scans. And additionally, there are limited tests approved for clinical purposes. Now let's move to talk about the risks and benefits of biomarker testing. As you are likely aware, much of biomarker testing in the AD space has really occurred in research settings, and particularly in the Alzheimer's Disease Research Center, or ADRC, network, as these are the group of centers that really lead the way in many different Alzheimer's studies. A few years ago, Scott Roberts, a colleague here at the University of Michigan and the lead of our Outreach, Recruitment, and Engagement Core, conducted a study as part of the Advisory Group on Risk Evidence Education in Dementia, or AGREED Dementia. To tell you a bit more quickly about AGREED Dementia, This is a group of broad clinicians, researchers, stakeholders, patients, individuals living with dementia or mild cognitive impairment, caregivers, lawyers, bioethicists, etc. So a very diverse group of folks, all of whom have an interest in how research results or clinical results are delivered back to participants. As part of this group, there are several different committees, and Dr. Roberts at this time was leading the Asymptomatic Disclosure Committee. As part of that committee, he conducted a survey of the Alzheimer's disease research centers to determine what information was currently being disclosed. Through that survey, it became clear that most of the Alzheimer's disease research centers were delivering back sort of the standard of care results, so neuropsychological test feedback and research diagnosis. However, fewer centers were disclosing amyloid PET results, particularly to individuals who are asymptomatic, and the same was true of tau imaging or tau PET results. So why might this be? Probably because there are significant challenges to disclosing biomarker information or even engaging in biomarker testing. First, often comes down to money. So biomarker testing, as we've discussed in the previous slides, can be extremely expensive. But additionally, disclosing the information requires time, personnel, skills, etc., that really do require additional funds. In research settings, we know our funds tend to be finite. We have a specific budget for each grant, and so it makes it challenging to expand beyond that budget to be able to share results. Additionally, biomarker testing and specifically disclosure takes a significant amount of time. It means additional meetings with participants, additional training for staff and faculty, and those that might be involved in the process, additional tracking. With all of that comes a concern for additional burden on participants. There's a question of whether participants really want this information or whether we're creating more visits for them, more time, more procedures that they have to undergo. And finally, there's a limited expertise in biomarker disclosure specifically. It's a relatively new area, and up until very recently, there were few protocolized approaches, tools, scripts, training materials, etc. So there are many centers and research teams who are conducting biomarker testing, but may be unsure about how to share this information. There are significant legal challenges to returning results as well. Many of you will be familiar with the Genetic Information Non-Discrimination Act, or GINA. This is a piece of legislation that essentially protects patients who have recently learned genetic testing results from experiencing things like medico-legal discrimination. Essentially, if a person decides to get testing for some kind of genetically coded disorder, the genetic information goes back into their medical record, and it can be reviewed by insurance companies, medical providers, and potentially even employers. In that case, the information is protected, which means that those employers, medical providers, and insurance companies cannot use this information to make decisions about a person's eligibility or opportunities. In contrast, there is currently no Biomarker Information Non-Discrimination Act. What this means is that a patient or a participant could complete AD biomarker testing, the result could end up in their medical record, could be under review by insurance companies or other entities, and the information could be used to make determinations, for instance, about things like their long-term care insurance eligibility. Another factor to consider is where AD biomarker testing is in relation to cognitively symptomatic versus asymptomatic patients. As of right now, as we'll talk about later, in clinical care, biomarker testing is only advised for people who have cognitive symptoms. However, we are certainly moving in both research and eventually in clinical care to treating people before they've developed symptoms if they're potentially at risk. What this means is that individuals who are cognitively asymptomatic, they may be more likely to be younger, they may be under the age of 65 and not already have Medicare, which means there's a chance that they may be uninsured or underinsured. So the impact of their information on things like insurance eligibility would be important to understand. Another important set of regulations to consider is the Clinical Laboratory Improvement Amendments, or CLIA. These are the set of federal regulations or standards that apply to all U.S. facilities that conduct testing of human specimens for health purposes, even if that's health research. The general policy from CLIA suggests that research results disclosure should only be conducted if samples were collected through a CLIA-certified laboratory. However, there are several potential exceptions that are spelled out in the CLIA document. The first is if a research participant requests the information or refuses to continue participation in the study without having their information released to them. That may justify the release of information from a non-CLIA certified lab. Additionally, if the testing that's conducted in the non-CLIA certified setting could warrant further clinical testing, it should be released to the participant. Additionally, if the experimental test is the best available or the only available test to the participant, that also may be grounds for releasing the information, regardless of whether it was collected in a CLIA certified lab. Now, of course, this law is really to protect participants because we know that the validity and reliability of the data that we share back with participants is contingent on how the information, how the sample was collected, how it was analyzed. So CLIA certification does add sort of a level of legitimacy to the work that is being done. However, CLIA certification costs money. Many research studies, laboratories, teams are not using a CLIA certified lab. And that may not be sufficient information or sufficient barrier to not release information back to participants. In summary, the CLIA regulations are incredibly nuanced, and it's important that we don't use those solely as a crutch to not release information, but rather understand under what circumstances it may be okay to release research results. In addition to the practical and legal factors, there are absolutely some personal risks of disclosure that we're still trying to really quantify. One major barrier to particularly research-based disclosure in the past has been a concern from research teams and clinicians that participants may have negative psychological effects of learning that they have an Alzheimer's disease biomarker present at an elevated level and are therefore at greater risk for developing dementia in the future. Some of the psychological risks that we're concerned about include things like increased worry, sensitivity, and hypervigilance about symptoms. So a concern that regardless of what your actual cognitive abilities are, that you may perceive yourself as performing more poorly. Also depression and anxiety, so clinical syndromes or clinical disorders as a result of learning your results. And certainly we're always concerned about suicidal ideation or suicidal behaviors. There's also a concern about stigma. So if a patient or participant decides to share their results with individuals around them, they may be treated differently by others, including friends, family, community members. For instance, we all have everyday memory failures that are very normal based on our lack of sleep or inattention. I may put my coffee cup down somewhere and forget about it. In most cases, I see that as a pretty benign sort of experience that likely happens to everyone. But if my partner knew that I had evidence of elevated amyloid, perhaps they would view that relatively benign everyday memory failure in a different light, and they would start treating me differently because they thought perhaps that's a harbinger of something worse to come. And finally, as we've touched on a bit in previous slides, there's a concern about medico-legal discrimination. This is basically a concern that participants or patients who decide to share their results in their medical record or with their employers may be denied medical services, legal opportunities, advanced planning like long-term care insurance eligibility, or employment opportunities based on their results and the presumed trajectory of those results. So now that I have provided some of the barriers or concerns about biomarker testing, I really want to shift gears and talk about why I think biomarker disclosure is important and potentially beneficial. Let's start with talking about the potential impacts for participants. One factor that has become really clear in recent years, as I'll discuss in future slides, is that participants feel that information they share with us is their information. We are borrowing it, we don't own it. And so there is a concern, or at least a strong feeling among participants, that they have a right to receive their research results on the individual level. In fact, a couple of years ago, Sarah Walter and others from the stakeholder committee of the Agreed Dementia Group that I described earlier published a paper called the Participant Bill of Rights. This is a document that indicates that participants feel that they have a right to receive their individual level results following AD research participation. This really gets down to two ethical concepts: this respect for autonomy and a right for participants to know or not know their results. But in addition, we're beginning to accumulate quite a bit of evidence to show that there are beneficial effects of engaging in biomarker testing and disclosure. From the IDEA study, we now know that when a participant completes biomarker testing and that information is shared with their medical provider, medical providers have greater diagnostic confidence. They feel like they engage in more personalized treatment planning and monitoring. There are also potential impacts directly to the participant. Participants who find out that they have elevated AD biomarkers are more likely to plan to engage in things like diet and exercise, other health behavior changes. They may use the information for advanced planning, like making decisions about housing, long-term care insurance, who will make decisions for them if they become unable. We also are beginning to gather some preliminary evidence of an impact on family members or potential care partners. For instance, knowing an AD biomarker test results may allow a caregiver to prepare for that role more thoroughly than they might have in the past. And finally, there's undoubtedly some impact for patients in terms of gaining access to clinical trials and treatments. At this stage, biomarker testing is becoming more and more common in AD clinical trials, in part to increase the homogeneity of the sample that's engaging in the study in hopes of really getting greater target engagement. This also allows us to be a lot more efficient in the way that we do clinical trials. It also allows participants, engaging in biomarker testing and disclosure may allow participants to gain access to some of these novel disease-modifying therapies that require evidence of amyloid positivity. There are also potential benefits of biomarker disclosure for researchers, research teams, and research participants specifically. As I'll talk about on the next few slides, disclosure of research results might present an opportunity for bidirectional communication with our research participants, which in itself increases transparency and personal benefit to participants, which then in turn may enhance more diverse participation in ADRD research. It's also true, as I've previously mentioned, that biomarker positivity is now an eligibility criterion for many clinical trials. So one means of diversifying and increasing enrollment into those clinical trials is by disclosing results. There are also several teams that are doing an excellent job of really studying biomarker disclosure from a recruitment science perspective. Folks like Jason Karlowish and Josh Grill and their teams have worked really carefully at teasing apart what parts of disclosure are useful versus not useful in enhancing clinical trial recruitment. They found that the requirement to learn one's biomarker result doesn't discourage participants from enrolling in ADRD research. In fact, there's now quite a bit of evidence to suggest that it enhances recruitment and participation. Participants are also not concerned about having their results shared with a study partner if they participate as a dyad in ADRD research. In fact, they tend to prefer that. Additionally, novel blood-based biomarkers may really reduce the time, cost, and access barriers that sometimes hinder enrollment into studies. So if participants feel like a PET scan or a lumbar puncture would be too invasive, too costly, too time-consuming, then potentially they're not going to take part. But blood-based biomarkers, as in clinical practice, could really enhance research identification of those who might be a good fit for AD studies. One study that I really want to highlight here is by Jen Lingler and colleagues at Pitt. This was a really interesting study looking at recruitment and retention in AD longitudinal studies. They conducted qualitative interviews and from that did a factor analysis to determine what really motivated folks to engage in this kind of research over time. And they found two different factors. The first was an altruistic factor. This is really the kind of information that we talk about in our consent forms, that the majority of the benefit of engaging in research is to the science, to advance the science and move things forward. However, they also found that many participants talked about personal benefits of engaging in research that included things like gaining access to future treatments, learning more about AD, accessing medical care, etc. The team also looked at characteristics of the participants that might map onto the altruistic or personal benefit motivators. They found that participants who had cognitive difficulties, as characterized by a CDR greater than 0, were more likely to emphasize those personal benefits. Now that makes sense. If a person has cognitive difficulties, they may be more motivated to gather as much information from a study as they possibly can for clinical purposes. Authors also found that Black and Asian participants were more likely to emphasize personal benefits. When we contextualize this into known disparities in access to care for non-white participants and patients, it makes sense that potentially individuals from these communities may see research participation, particularly if they're able to learn their results, as one means of accessing this more specialized care. In this study, they also looked at barriers to engaging or being retained in these Alzheimer's disease studies, and they found a now fairly well-recognized finding that Black participants are more likely to have concerns about the privacy of their information. Now, this makes sense in terms of the current and historical violations that have occurred at the hands of medical researchers at the Black community. However, in this study, they also found that trust in medical researchers completely mediated this relationship, essentially saying that if trust could be built between the participant and the medical research team, that may significantly assuage concerns about privacy of information. So I'm going to argue that one way that we build trust with participants is through greater transparency, greater communication, bi-directional communication. So I would argue that return of research results may heighten personal benefits and also reduce mistrust in research through that transparency. And these two factors may ultimately lead to better recruitment and retention, particularly among participants from minoritized communities. To move to the final part of this talk, we're going to discuss the ethical and cultural considerations for biomarker disclosure. I'll also be talking a little bit about our framework for biomarker disclosure embedded throughout this part of the talk. So again, these are those ATN curves. These lines that are represented here really talk about when we tend to interact with potential patients or participants. So as a neuropsychologist, I most often see participants at this time of clinical or phenotypic diagnosis. So the time at which a participant already has significant symptoms, and if they do have Alzheimer's disease, there's already been that significant buildup of amyloid and tau. The challenge here is that in the absence of therapies that have been shown to halt or significantly reverse symptoms once present, it means our treatment window is relatively short. What biomarker testing can do is potentially widen that window to bring it back before a person has significant symptoms. But how do we go about sharing this information with participants in a way that is practical and ethical? There are several different ethical considerations that map on to different aspects of the biomarker disclosure process, and we're going to walk through each of those. The first ethical consideration is this idea of the right to know versus a desire not to know. Again, kind of respect for autonomy themes. The questions that arise as part of this ethical consideration would be things like, do patients and participants really want this information? Why or why not? Another ethical consideration is one of competency. What makes a clinician or a researcher competent to share these results? All of us in the clinical fields have codes of conduct, and all of us within those codes of conduct have specific considerations around whether we are competent and what makes us competent to execute different clinical services. A third ethical consideration is protection against risks versus this respect for autonomy. Is it true that we should share all results with all participants all the time? When we're talking about a group of participants who, in some cases, by definition, are more likely to have cognitive impairment or already have some cognitive impairment, we must also ask the question of whether or not patients and participants have the decisional capacity to understand the risks and benefits and potential utility of biomarker disclosure. We also have to think a little bit about what happens after disclosure. As, again, clinical researchers or clinicians, we are always balancing this concept of do no harm and do as much good as possible. So as part of that, we first have to ask, how well can we actually communicate this biomarker information? Will patients and participants understand this highly complex information in a way that's useful? We also want to know whether or not biomarker disclosure is safe. I mentioned earlier our concerns about psychological distress and other outcomes. It's important to explore more. And finally, we need to know how patients plan to use this information over time. Is it actually useful? Does it promote any changes in their behaviors or thinking? And finally, too often, we tend to ignore the contextual factors that might moderate or mediate effects of biomarker disclosure. We need to ask whether risk or biomarker disclosure needs differ across groups and how social determinants may impact how different groups respond to learning their biomarker results. I'm going to start by talking about this first ethical consideration. In addressing this ethical consideration, it's important that we understand whether participants actually want to know their AD biomarker results. The good news is that we now have over a decade worth of research addressing this question. Even before biomarker tests were clinically, commercially available, we know that public interest was very high. So in previous studies of hypothetical AD biomarker testing, over 2/3 of participants indicated that they would be somewhat or likely to get an Alzheimer's test if they could. Various participant characteristics predict whether or not you might be interested in receiving your AD biomarker results. Those include folks with a history of subjective memory complaints, family history of dementia, history of caregiving for someone with dementia, or older age. This makes sense. So participants who have risk factors for Alzheimer's disease or who have experienced Alzheimer's disease firsthand in one way or another may be more likely to engage in this kind of testing. Now that study finding has now been replicated across several different studies. Most recently, colleagues from the School of Public Health here at the University of Michigan examined data from the National Poll on Healthy Aging. This is a pretty broad community-based sample that conducts questionnaires asking about all different aspects of health. And in this national poll on healthy aging, 80% of respondents indicated that they would be interested in a blood-based biomarker test for Alzheimer's disease. Various folks have also looked at whether this is true among certain communities. So Fred Ketchum and colleagues at the Wisconsin ADRC studied whether participants from minoritized backgrounds are interested in engaging in Alzheimer's disease biomarker research. And they actually found that the primary predictor of recruitment and retention in these kinds of studies for minoritized communities is whether results will be received back. Now, we became very interested in this topic in our own Alzheimer's Disease Center here at Michigan. We wanted to know whether our participants who had taken part in things like amyloid and tau PET scans previously would be potentially interested in learning those results, even though they were not offered those results at the time that they conducted their biomarker test. They thought they were just participating in a research study. So what we did is a needs assessment. We collected data from several different dyads coming from Black and white communities around the Detroit metro area. And we specifically asked for participants who were cognitively healthy or diagnosed as having mild cognitive impairment, that prodromal stage of dementia. We also asked that they bring with them a study partner who was either their current care partner or the person who would serve in that capacity in the future. These individuals or dyads went through a mixed methods interview in which we conducted some questionnaires, but also asked several open-ended questions about things like their perceived vulnerability to Alzheimer's disease, their interest in engaging in biomarker testing, their interest in receiving the results that they had already completed as part of research participation previously. And I have the results depicted on the next slide. So as part of our mixed methods interview, we asked participants how interested they were in receiving PET amyloid and tau results in two different ways. First, we asked about general level of interest, but then we pushed a bit further and said, if we had a test available for you today, or we had your result available to you today, would you choose to receive the result? And we saw pretty universal interest. So participants indicated high interest in PET biomarker results, regardless of race and regardless of diagnosis. So somewhere between 97 and 100% of participants said that they would elect to receive their results if available. We also saw strong interest among care partners, though there was a race effect, such that Black care partners were a bit more reticent about receiving their loved ones' PET results. We also asked participants why they wanted to know their results, and we did this in a range of ways. First, we asked them several open-ended questions to tap into their motivations for wanting their personal results. We specifically did not want to give them a list initially, in part because we wanted to see what participants knew about biomarker testing without any kind of education, how they expected to use their results, etc. Following these open-ended questions, we provided a list of all possible benefits that we could come up with, and we allowed participants to endorse any that applied to them, so select all that apply. Finally, we asked them to go back and choose among the list of those they had selected the primary motivator or primary benefit that would motivate them to want to receive their amyloid PET and tau PET results. And that is what we have depicted here. Now, I recognize that this is quite a busy slide, but in some ways that's exactly what I want to convey. The gestalt here shows that there are highly varied and very diverse reasons why participants might want their information. We also saw from those open-ended questions that participants significantly overestimated the level of accuracy and the level of information that would be received from a biomarker test, such that participants felt that a biomarker test would tell them when they would develop dementia, how many good years they would have left, what kinds of symptoms they might suffer, how severe their symptoms might be, and therefore what kinds of services they might need and when. Now, we know that biomarker tests can't tell us that level of information, so that's really critical to think about as we consider ways to educate the public about biomarker testing. Now, we also asked participants why they may not want to know a biomarker result. We used the same format in which we first asked open-ended questions, then we provided a list of all potential risks or barriers of biomarker disclosure, and finally asked them to go back and select the primary risk or barrier that would stop them from wanting this information. Now here we saw a very different pattern. We saw that between 80 or over 80% of both participants and care partners indicated that there were no risks and no barriers to learning their biomarker results, or at least that would stop them from wanting those results. To me, this points to two separate conclusions. First, participants really want this information. They see it as something that they could use for personal benefit, just like we saw in the Langler study. With that said, this also shows me that there's a real ethical need for us to educate participants about what risks might be relevant for them. So now let's talk a bit more about the second ethical consideration of competency. What makes someone competent to share these results? The reality is that we don't have good guidance on this quite yet. However, I would argue that there is no discipline or training background that is specifically required for disclosure. And in fact, interdisciplinary teams may be the most effective teams at thinking about all aspects or all elements of disclosure. Here at the University of Michigan, we have a pretty broad team that are involved in our biomarker disclosure and neuropsychological test feedback. Those include physicians, folks like primary care physicians, geriatricians, and neurologists. We have several clinical psychologists, neuropsychologists, and health psychologists, full-time social workers, advanced practice practitioners, folks like advanced nursing, physicians associates. We also do have trainees involved in our disclosure process under significant supervision. The one thing that I will argue is that a clinical license is strongly preferred. At a minimum, significant clinical experience is required. That is in part because we are still trying to understand the safety profile of disclosure, and it's important that we have individuals on the team who are able to engage in thoughtful risk assessment and planning and follow-up as needed if a participant does have a negative reaction to their results. There are several different elements of competency or content area knowledge that would be relevant for disclosure. I have some of them listed here, though of course this is not a comprehensive list. These are just some of the factors that we consider in training our team. The content area knowledge includes everything from the psychometric properties of the biomarker tests, the risks and benefits of biomarker testing, and those cultural factors. But I would also argue that there are relevant skills, techniques, and even interpersonal characteristics that make someone a strong discloser. Those include things like a sense of empathy, skills in lay communication, so being able to break down really complex concepts into understandable language, using teachback or other methods to assess comprehension in a subtle way, risk assessment and safety planning, de-escalation techniques, so techniques that are specifically employed when a participant is having a really strong negative response, being able to manage participant interactions in the context of the family system, and also taking a strengths-oriented approach. So while the content area knowledge is relevant and something that I think we can all continue to grow in, it's important to also consider what our skills are as basic clinicians or human beings that might map onto successful disclosure. Moving to our third ethical consideration, protection against risks and respect for autonomy. Again, there's a question of whether results should be shared with everyone or whether there's a certain appropriateness for disclosure. There are several different documents and trainings that state kind of the current state of to whom we should disclose. At this stage, it is recommended that biomarker testing and disclosure should be done only in research settings for adults without cognitive impairment. And at least for now, biomarker testing for asymptomatic individuals is not indicated. I suspect that will continue to change as we move to focusing on those prodromal and preclinical populations in our trials in the future. In contrast, individuals with cognitive difficulties, so those who are symptomatic, can engage in biomarker testing and disclosure in both clinical settings and for research purposes. It's fairly common that happens. However, clinical stage is important in determining the relative utility, risks, and benefits for each patient or participant. Another important consideration is mental health. As we know, there are concerns about psychological distress being a significant negative outcome following disclosure, so it's important that we're not allowing participants who are already experiencing a high level of acute distress or unrest to learn results that could be potentially harmful for them. With that said, biomarker testing is not necessarily contraindicated in those who have any kind of mental health difficulty. However, it's a case-by-case basis kind of evaluation, and we'll talk more in future slides about how we might evaluate that. I want to point to two really excellent trainings that talk about these concepts in more detail. It's not as simple, though, as thinking about the participant's current diagnosis and their current mental health conditions. There are a range of different factors that affect appropriateness of disclosure. Those include, essentially, weighting the relative risks and benefits, but there are all these factors that weigh into risks and benefits that include participant demographics, the psychometric properties of the biomarker, participant clinical stage, participant decisional capacity, so whether they are able to demonstrate decisional capacity for this kind of complex testing, participant mental health, but also the context of the participant, so do they have sufficient clinical support, social support, mental health support. It's important that prior to biomarker testing, or at least prior to release of individual biomarker results, that some level of clinical screening is conducted on a case-by-case basis to determine whether the particular patient or participant is a good fit for learning their results. Here at the Michigan Alzheimer's Disease Research Center, we do disclose results not only to individuals who are cognitively symptomatic, but also to eligible individuals who are asymptomatic. So part of our screening process is not necessarily contacting the participant for screening, but rather reviewing the information that we've already collected about the participant. So we confirm things like their current diagnosis based on our consensus process. Additionally, we evaluate access to clinical care. Many of our participants here at our center are not connected with our University of Michigan healthcare system or any healthcare system at all. So it's important that we consider not only whether they currently have access to someone like a neurologist or a geriatrician that could help them contextualize and utilize their information from a biomarker study, but if they do not have access, how can we provide access, or at least provide some kind of pathway to gaining that access? We also consider the relative clinical utility and risk versus benefit profile for each participant. What we mean by this is that we weigh their different clinical and patient characteristics, as well as their risks and benefits, to determine if biomarker testing and disclosure is right for them right now in this particular setting. I have several examples here that might demonstrate what I mean. So for instance, we have several participants who are cognitively healthy, so they don't have symptoms themselves, but have engaged in biomarker testing as part of AD research because they have a family history. They may be deciding to make some general sorts of changes, so talking to their doctor about their family history or engaging in some kind of screening or neuropsychological testing. In this case, this is a participant who might be at higher risk for some of the negative outcomes following biomarker testing. If they don't have symptoms, perhaps they're slightly younger, they may still be working, and therefore they may be at higher risk for medico-legal discrimination if their result indicates that they have evidence of Alzheimer's disease. Additionally, if they don't have a clear purpose for the information, but are rather just considering next steps, perhaps biomarker testing isn't relevant at this specific time. In contrast, we can take someone like example 3. We have many participants who complete biomarker testing as part of their ancillary studies to confirm whether their current diagnosis of dementia is due to Alzheimer's disease. In this case, a person with early stage dementia likely already has a documented diagnosis in their medical record, evidence of cognitive impairment, and so the risk of medico-legal discrimination based on the new biomarker information may be relatively lower. Equally, the extent or the impact of the biomarker information may be more limited. Really, we're just clarifying the potential etiology that's driving the person's cognitive difficulties, whereas it's really their cognitive difficulties themselves that are likely to guide the need for advanced planning. We also conduct pre-disclosure mental health screening. As I mentioned before, participants who have some mental health history are not necessarily excluded from engaging in biomarker testing, but we do expect that participants should have stable mental health and sufficient coping strategies and resources at their disposal, just so that they are able to cope for the potential outcomes of a biomarker test. So some depression, anxiety, or behavioral issues may be acceptable, and in some cases may even be expected based on the population who are likely to be interested in biomarker testing, those who already have some preliminary symptoms. However, the level of pre-disclosure screening really has to be guided based on the person sitting in front of you or the population that you're targeting. So for instance, if you're working with a sample of participants who have already engaged in clinical trials in AD, or you've already run a clinical trial, chances are that clinical trial excludes individuals who have severe mental illness, acute and significant mental health difficulties. And so potentially if the mental health history is known and known to be stable or minimal, it may be okay to use a quick screen to determine whether or not disclosure is appropriate, something like a PHQ-7, GAD-7, PHQ-2 even. If we're talking about the broader community, or a sample or patient population with unknown mental health history, it may be important to use a more comprehensive pre-disclosure mental health screen, something like the GDS-15 or the BEAI. And of course, if there is evidence of prior mental health conditions, or if there are concerns that arise on any of those screeners, it's important to have someone on your team who's competent to complete a more thorough interview that includes things like past and current mental health symptoms, treatment, risk assessment, and potentially some measures of suicidal ideation. It is also important to consider not just the scores on these measures. So yes, we encourage you to use some kind of quantitative measure and cutoff that would be a trigger as part of your protocol. But it's also important to contextualize that score within an individual's current mental health more broadly, their social support, and their protective and coping resources. So we've had several participants who had elevated scores, for instance, on something like a GDS, maybe for a completely unrelated reason. Maybe they recently had a hip replacement, and that has caused them to drop many of their activities. They're experiencing pain, that's frustrating, but they still are competent in other ways and appropriate in other ways to receive their biomarker results. There's also the question of decisional capacity. So decisional capacity is not a sort of singular or universal construct. It's not true that a patient or a participant just has decisional capacity or does not, broadly speaking. Decisional capacity has to be assessed for the specific participant, the specific decision at hand, at the current time, in the current setting. And so what this means is that we need better ways of being able to assess whether the participant or patient in front of us at this time is able to understand the utility, risks, benefits, and alternatives associated with biomarker testing specifically. There are various ways to assess decisional capacity. Again, when we're talking about a population that is relatively less impaired or has no cognitive impairment, it may be sufficient to offer educational materials about biomarker testing and disclosure and verify that the participant or patient doesn't have questions. When we're talking about populations who do have significant cognitive impairment, it's probably more important to assess all elements of decisional capacity using something like a mixed methods or qualitative interview. I want to review some of the elements of decisional capacity and some of the relevant questions that might be asked to map onto or assess each of these elements. So the first is understanding. In this case, this would be understanding of what's involved in a biomarker test, alternatives to engaging in that test, also what would be involved in biomarker disclosure, what they may learn or may not learn. Important questions here include things like, what is involved in a biomarker test? What will a test tell me? What won't it tell me? Going back to those early slides where I talked about some of the misconceptions about what biomarker tests might share coming from our community participants, it is really important that we emphasize exactly what a biomarker test will say and what it won't. The second element of decisional capacity is appreciation of risks and benefits of biomarker testing. So going through what those risks and benefits might be for the participant. Also, communication of choice and rationale or reasoning. This is really the patient or participant's ability to take that information, that knowledge that we've just shared with them, the understanding and appreciation, and to apply it to their own situation and their own life and explain their rationale or their balancing of risks and benefits to make a clear and consistent decision. Now, this is something that we wanted to assess in our own participants. We asked the question of whether participants who had significant cognitive impairment were able to independently or with assistance make informed decisions about receiving their results. We felt it was particularly important to first provide some very clear education about biomarker testing as well as Alzheimer's disease more broadly. So in our own studies, we have a one-on-one session with participants and their loved ones. This is before testing has occurred ideally or before disclosure decisions have been made. So whether the participant and the study team have collectively decided whether to move forward with disclosure. This is a one-on-one session in which we use several scripts and training materials as you see here. As part of these training materials in this session, we have embedded questions that are checks for understanding, but actually map onto different elements of decisional capacity. So that qualitative interview that I mentioned just on the previous slide. We ask these questions first to the participant to deem and understand whether the participant is really understanding and grasping the knowledge that we're sharing with them and really able to apply it to their own situation. However, in this case, these were participants who had a diagnosis of mild cognitive impairment or early stage dementia. So we also always include a study partner, again, the person that's currently serving as a care partner or would be likely to serve in that role in the future. If the participant is unable to be able to answer these questions accurately, we tag in the care partner and we allow them to answer the question or discuss it further with the participant. And we record those answers and then code the answers to see whether or not they demonstrate these different elements of decisional capacity. Now, some will ask us, well, why do we involve care partners? In part, it's because we feel very strongly that this is how decisions are made in real life. When I make a decision about my health or engaging in some kind of test, I'm likely to talk to trusted others like my spouse, my family members, my friends, to help decide whether or not this is the right fit for me. And so we want to be able to mimic that real life conversation and the support or shared decision making that occurs with a care partner and a loved one. Here are the results of that study thus far. It is an ongoing bioethics study, so we are about 2/3, close to 3/4 of the way through. But the preliminary data are pretty convincing. They show us that, as we might expect, individuals with mild cognitive impairment, so those who are earlier on that phenotypic spectrum, were better able to demonstrate understanding, appreciation, rationale, and therefore overall decisional capacity for disclosure than those with dementia Alzheimer's type. course, this makes sense to me. However, we also saw that incorporating study partners or incorporating care partners was really helpful here, because the care partners who themselves were cognitively healthy were able to really fill in the gaps and lead a conversation with a participant that showed shared decisional capacity for this kind of assessment. Now, I think that these results really have important implications for clinical care. First, let's think a little more about how we go about offering tests and procedures in research and clinical settings. In research settings, we do have a consent form where we speak very overtly about risks and benefits, but that's not always true in clinical settings. Often, if a provider offers us a test, they may provide a little bit of information about what the test will tell us, and it's based on their best guidance and their best advice. That's not to take away from that guidance and advice. It comes from significant expertise. But what these results are showing us is that it is really important to take the time to go through risks, benefits, and utility, and to actually assess those in the participant rather than just asking, do you want the test, yes or no? Because we know participants, even those with significant dementia, are able to say yes or no, but they may not be able to describe why. Okay, moving swiftly forward, that balance of do no harm and do as much good as possible. The first element of this is really assessing whether or not we are successful in communicating this information in a way that participants understand. In thinking about the topic of whether we can communicate these results clearly in a way that's understandable to diverse participants, we have to ask, why are biomarkers so challenging to disclose? First, when we're talking about biomarkers, we're addressing underlying etiology. So what we're talking about is biomarkers communicating Alzheimer's disease presence or absence, but not necessarily the presence or absence of dementia Alzheimer's type. As I mentioned earlier, one very common misconception is that a biomarker test can tell the patient or participant whether they have dementia, whether they'll develop it, and at what rate and severity level. We know that that's not true, and that's really important to clarify as part of our disclosure process. Additionally, our context is sometimes limiting. When we're communicating research-based AD biomarker results, it's very important that we don't toe the line of taking the place of a clinical provider. We want to convey information that may or may not be clinically actionable, but we also want to emphasize that what we're sharing is not a clinical diagnosis. In the age of disease-modifying therapies, it's also important that we communicate that a biomarker test conducted in a research setting may or may not qualify or disqualify a participant for certain types of clinical care. There are clinical biomarker tests available, and those may be repeated for the purpose of determining eligibility for a therapy. Biomarkers are also dynamic in nature. So unlike genetic information, which is static, when we're communicating a biomarker result today, that result may not be the same as a biomarker result received a year from now. One challenge in particular is communicating when a person has currently not elevated results, so their scores fall below a certain threshold or cutoff. Here we want to communicate that yes, this is good news, the individual is currently not elevated. However, that may not be the case in the future. Additionally, we have to be careful about talking about prognosis. Having an elevated AD biomarker result can convey an increased risk for developing dementia, but it is not a definitive dementia prognosis. We cannot tell participants how many good years they have left. We cannot tell them when they will develop dementia, when they will pass away from dementia, or if either of those things will happen. And that can feel very dissatisfying to participants. And finally, we can only see one piece of the clinical picture as part of an AD biomarker test. What I mean by this is an elevated result can be used to rule in Alzheimer's disease, but it can't necessarily be used to rule in or out other potential conditions or contributors. We know that most dementia is multifactorial and multi-etiologic, so there are often many contributors and many pathologies, but we can't always speak to those in part because we don't have good biomarkers for many of the other pathologies. So it's important that when we're communicating these results, we are discouraging participants and patients from being too myopic about Alzheimer's disease. Certainly, this is particularly true when we have few treatments to halt or reverse symptoms of Alzheimer's disease once present. We really want patients to focus on the many other potential factors that are driving or worsening their symptoms, as those might be better targets for intervention. What I have listed here are some of the language that we use around communicating biomarker results, but more importantly, the steps of interpretation. We tend to describe the meaning or the headline, the label for the result first. So for instance, an elevated amyloid result means that there's a significant amount of abnormal amyloid in your brain. We then describe what that means in terms of Alzheimer's disease. So for instance, if someone has evidence of amyloid, we tend to say this result means that there may be Alzheimer's disease brain changes already occurring in your brain. We describe the relationship to cognitive problems if the person already has them. So if the person's impaired, we may say something like, your thinking changes are likely due in part to Alzheimer's disease, not just due overall to Alzheimer's disease. Again, there's probably other pieces of that puzzle, but they're due in part. And then describing risk for future decline. Note that we say it is not guaranteed that you will go on to develop dementia. We like to lead with this because we want to provide participants with some sense of control or hope, and because at this stage we again cannot definitively say if and when the participant will develop dementia based on a biomarker result. However, you are at increased risk for developing dementia in the future. We also then communicate some of the limitations. Many of these I've already talked about, but I want to mention that at this stage we don't release specific numbers, percentiles, in part because there's no universal biomarker or threshold or cut point for positivity. Those vary across tracers, across sites, across modalities, but also because at least at this stage, we don't have sufficient information to know that 5-point centiloid increase, for instance, in amyloid, relates to an increase in risk of X% of conversion to Alzheimer's or to dementia. In the future, we expect that we'll get better at combining factors and utilizing biomarkers along with other patient and participant characteristics to predict more prognostically, but we're just not there yet. Again, we emphasize that if a person's negative, we can't guarantee they'll remain negative. We can't rule in and out other neurodegenerative or other possible comorbidities. We can't predict if, how, and when decline will occur. At least at this stage, again, we're not able to accurately combine risk factors to predict trajectories. We have some general ideas about how to how to combine genetic and biomarker information, but we're not able to do that at the level where we can very precisely talk about risk of conversion. And finally, there is limited research with racial ethnic minorities and some evidence that these tests might perform differently or that there might be different cutoffs appropriate for different groups. And so that does mean that biomarkers should be disclosed with care in these populations. That doesn't mean not disclosing them, but rather being relatively transparent about the lack of information we have in that space. So we wanted to look at our own samples of folks who had undergone amyloid and tau PET disclosure to see whether they understood and recalled this really complex information. So this is, again, data from that ongoing bioethics supplement. The first thing that we do as part of this study is we assess rote recall of results. So we do have a questionnaire that essentially asks, was your amyloid elevated? Was your tau elevated? And some other basic follow-up questions. We ask this information immediately following the disclosure session. We also ask it 1 week later and 6 weeks later. This again is in the sample of participants who have either mild cognitive impairment or early dementia that's presumed to be due to Alzheimer's. And so what I have depicted in this first figure here is their accuracy score on this rote recall questionnaire. We saw a medium diagnosis effect. What we mean by this is that, as we might expect, individuals with mild cognitive impairment who have fewer memory impairments have higher recall of their results at the 1 and 6 week time point. Similarly, we saw a medium effect of amyloid status. So those who were amyloid negative, again, those who potentially might have fewer memory problems specifically, had better recall of their results immediately and at 6 weeks. But there was no interaction between diagnosis and amyloid status. Now, a challenge of looking at rote recall is that people can recall the words that you share with them without understanding the meaning. One of the very common anecdotes that we hear among teams who share results as positive versus negative is that there can be confusion about what positive means. So for instance, a participant may hear, I'm amyloid positive, and think, well, positive, that has a pleasant kind of association, and so that must be good news. So we also look at recall of the meaning of the result. So what this result actually means in terms of whether or not there's evidence of Alzheimer's, whether I'm at risk for further decline. So here we did not see any effect of diagnosis or amyloid status, and we actually saw a higher overall score in terms of meaning of result. So what we're seeing from this preliminary data is that there's generally strong comprehension and retention of results overall, though it does seem that those with greater impairment might have more difficulty holding on to some of the rote information over time. And this really calls for care partners and others to be involved in our disclosure appointments, and also for us to ensure that we're sending written documentation of a result home with a participant, just to help boost that recall over time. The next question when we're balancing do no harm and do as much good as possible is this idea of whether disclosure is safe. So we can look at that in a range of different ways in our current samples. So this is the same sample of participants who have recently undergone disclosure. We give several different measures. We give the Beck Anxiety Inventory, the Geriatric Depression Scale, and something called the Impact of Event Scale. To start with, let's talk about the Beck Anxiety Inventory. So this is a 30-item measure that assesses how bothersome different anxiety symptoms have been recently to the participant. Scores range from 0 to 63, with scores above 16 indicating moderate anxiety. And what you can see here is that there was no difference in pre- and post-disclosure anxiety by amyloid status, though there does seem to be a medium effect, not significant, at week 1, where individuals who are positive for amyloid and found out they were positive for amyloid might be slightly higher. However, there's no indication that this is a clinically significant difference, even if we had a larger sample. Scores were all at or below 5, which is well below that 16 cutoff for kind of clinically relevant anxiety. We saw a very similar pattern for measures of depression. There were no differences in pre-post disclosure depression by amyloid status or by diagnosis, and all effect sizes were really small, or all scores fell sort of at or below the 2 to 3 mark, which is below the cutoff of 5 for the Geriatric Depression Scale. We did not have any study-related adverse events, so nothing, no suicidal ideation, no new onset or exacerbated clinical symptoms. One note that I don't have depicted here is that we do give a measure called the Impact of Events Scale and various modified versions of that scale. That scale is specifically measuring distress or positive reactions to learning a specific test result. Here we found, and various other research teams have found a very similar finding, that there is some acute test-related distress that occurs immediately following disclosure of results. However, that tends to diminish fairly quickly within 1 or 6 weeks of disclosure, and does not seem to again be at a stage that it's motivating clinically relevant symptoms. On that measure, there is a question about decisional regret. The final question, I believe, on that measure is, do you, how much or how often do you regret learning your test results? And to date, no one in our studies have endorsed any level of regret of learning their results, which I think is a really important kind of marker for us to monitor. These results are very consistent with other AD biomarker disclosure studies, so most find that if there's going to be any effect, it will be test-related distress very acutely, but quite mildly. That doesn't seem to translate to other measures of anxiety, depression, mood, negative affect, etc. One challenge, however, is that most disclosure studies, including my own, have incorporated participants primarily coming in from Alzheimer's disease research centers or who are being recruited for other trials. These are folks who tend to have, as I mentioned before, fairly stable mental health at the time they come in. In fact, they are excluded from studies if they have significant mental health conditions. But when we think about the much broader research and clinical implementation of biomarkers that's likely to occur in the next few years, biomarker testing in primary care, direct-to-consumer biomarker testing, we're talking about exposing a much broader population to these results. And we just don't know at this stage whether that much broader population, who are more heterogeneous psychiatrically, are going to react the same way. So more research is needed in this space. We do engage in post-disclosure counseling. I don't think that this is necessarily a required component of every biomarker disclosure protocol, but in the case where we are looking at effects of disclosure, we find it very important to have at least some resources available to participants. So researchers who are conducting biomarker disclosure are not expected to replace clinicians, but I do think it's an ethical expectation to provide some pathways to clinical services and to additional educational and mental health resources. I have depicted here some of the slides that we use in both our neuropsychological feedback and our biomarker disclosure protocols. These include things like localized mental health services, including services that are available on a sliding scale or through community mental health outlets, health behavior and lifestyle recommendations and classes, advanced planning services and connections, caregiver support, and educational resources. So now we've reached the final consideration, the respect for cultural diversity. Now, I'm not going to spend a lot of time talking about the performance of biomarker tests across groups, but I found one study that I'd like to talk about specifically, as I think it really depicts some of the findings that are becoming more evident as research with more diverse communities continues. So these are results from the IDEAS study, the secondary analysis from the IDEAS study. And in this study, they essentially matched participants from a variety of different racial ethnic groups, so Asian, Black, and Hispanic, with white, non-Hispanic participants. And they matched based on a variety of different characteristics, not only things like age, health markers, history of diabetes, for instance, but also cognitive impairment, access to care, those sorts of things. So they controlled for a lot of the factors that tend to drive disparities, and they still found that Asian, Black, and Hispanic participants had lower odds of amyloid PET positivity than white participants. Now, we need much more research in this area, and certainly we know that there is a crisis of underrepresentation in the Alzheimer's disease space. But these preliminary results do call into question whether there might be more appropriate and more personalized cutoffs for individuals from certain backgrounds, or rather whether we should be contextualizing AD biomarker information differently across these groups. I think it's important to note that that doesn't mean that we should not invite these participants to engage in biomarker disclosure. In fact, I would argue that that is unethical. However, we do have to be more comfortable with uncertainty and communicating uncertainty, which is maybe not something that we tend to be good at as clinicians and researchers. We're not always comfortable saying we don't have all those answers. So in our work, we do tend to talk about this, particularly when we're working with participants from our Detroit, Flint, and other communities. So how do we prepare for broader implementation of biomarker testing across diverse communities? I want to return to this really beautiful figure from Miranda and colleagues. Where I think AD biomarker testing, and specifically blood-based biomarker testing, could be most useful is by broadening access to these tools that had previously been, fairly selectively available through academic medical centers and research contexts. It broadens access. This broadened access, so the availability of a blood-based biomarker test in primary care, for instance, might really reduce this known disparity in how frequently, how early, and how accurately individuals from communities of color are diagnosed. That broadens that treatment window and really, could address this disparity very early in this kind of course that we see here. However, the tools for educating the public about and disclosing biomarker testing are very limited at this stage and have been primarily piloted with small groups, small samples of relatively homogeneous, wealthy, educated white women, the sample that we tend to recruit into many of our studies. And so there is absolutely a need to go beyond that. We need those protocolized disclosure approaches, but simultaneously we need to take those protocols and do site-specific cultural and community-based adaptation. We cannot be satisfied with a one-size-fits-all approach that we have used for developing so many different diagnostic tools and treatments in the past. I'd like to talk just very briefly about how we have started doing this at our center. It is absolutely a long-term iterative process, and we don't have it perfected by any means, but we try to hold one thought in mind, which is nothing about us without us. So nothing about this broad community without engaging the community in the decision making. So one of the things that we've done in my lab and my research program, the research program on cognition and neuromodulation-based interventions, is to think about how we pause after we develop our initial protocols to gather additional feedback and kind of meet the needs of the community. Our goals for this project, our community engaged research project, were to inform our current and ongoing disclosure protocols, to identify existing barriers like healthcare access, as well as facilitators like AD knowledge, to accessing biomarker testing and benefiting from their results, and also to identify knowledge gaps and myths about AD and AD biomarker testing that could be addressed through health education. So thinking again about how we have a responsibility to the community, not only to open up pathways to receive the testing, but also dispel some of the myths and educate the community about how it may be and may not be useful for them. We took a range of different strategies to really address some of these goals. So we went back following the initial development of our biomarker disclosure protocol, and we interviewed past participants who had undergone that protocol to ask them whether it met their expectations, what they would change, etc. We also conducted focus groups, and we carefully collected participants or recruited participants to these focus groups who came from all walks of life, primarily Black and African American older adults coming from Detroit and Flint. But we included participants living with dementia or mild cognitive impairment, care partners, individuals with a family history, educators, retired clinicians, factory line workers, individuals who had been involved in research before, as well as those who had never had any research experience, because we really wanted broad perspectives included here. We asked them to review our current protocols, our educational materials, and to give us feedback on what was missing. And let me tell you, this is a group of very blunt, very direct folks, and it was incredibly helpful. We also have a wonderful community advisory board, many of whom are coming from the Healthier Black Elders Center, which is part of our Resource Center for Minority Aging Research here in Detroit. And finally, we took all of the information that we learned and not only updated our protocols, which was a significant kind of step forward, but took the information back to the community through a series of community health education events, many of which were recorded and now live in an online library with some of our community partners. I do have some pictures from some of these events previously. One of our awesome partners is the Stoudemire, which is a wellness hub and a home for the Eastside Community Network organization in Detroit. We've also worked very closely, as I said, with the Healthier Black Elders Center of Detroit and Flint. So we're really happy to be able to partner across all of these groups. And I strongly encourage those who are interested in gathering more feedback to really figure out who in your community is already doing this work and who might be kind of the relevant stakeholders. So to end, I want to just review the disclosure framework. Many of these steps I've talked about in more detail today, but just as an overview, I want to provide kind of these steps again. So there's the collection, interpretation, and labeling of the data, determining appropriateness of disclosure, factoring in things like participant characteristics, diagnosis, social support, context. Engaging in some form of pre-disclosure education, either one-on-one or through brochures. Assessing decisional capacity and consenting, as appropriate to the group. Preparing for the disclosure appointment, so making sure that your team is well trained and comfortable in all of those areas of competency. Communicating both our results and our limitations. conducting comprehension and reaction checks, and assessing psychological fitness or psychological reactions, as well as engaging in post-disclosure counseling. Now, this general framework has now been supported and presented through various documents. I want to point out two really relevant readings. There's the ADRC Best Practice Guidelines led by Josh Grill and others. They're now available through the NAC website. And additionally, Emily Largent and colleagues, also at Penn, recently wrote a really excellent paper discussing this framework and some other steps for disclosing biomarker results. I want to end in summary by talking about the broad ethics of biomarker disclosure. There are all kinds of concepts and ethical constructs that we're weighting here, but ultimately the decision to return any health information is highly complex and has to be tailored to your team, the participant or patient in front of you, the timing, the setting, etc. So there's no one clear answer. I want to complete this video and complete this recording by acknowledging all of the wonderful people who have supported this work here at the center. Not only our funding agencies, the mentorship and clinical team that do this work day to day, but mostly the participants, their families, the community partners, and the advisory board. These are all folks that are willing to meet with us and talk with us about incredibly difficult, challenging topics, and in some cases share very vulnerable moments of their life with us, and I really respect and appreciate that honor. And I want to thank you very much for viewing this recording. I am happy to take questions at my email address listed below, and you can find me on the Michigan Alzheimer's Disease Research Center website as well. Thanks so much.